All right, got it.
So good afternoon, everyone, and welcome to the 10th episode of Genomics Gupshup. This is an initiative that we've taken at MapmyGenome because we wanted to build trust amongst the community and also build awareness about genomic tests that are still considered to be very difficult things for a lot of people, but we want to break it down into simple little bites that you can actually understand. So today we are extremely delighted that we have somebody who is an expert not just in pediatric neurology, but he's also been using genomic tests quite extensively over the last many years. So we are very delighted. Please welcome Dr. Rakesh Jain. He is a pediatric neurologist, much in demand for a lot of the things, because not only does he treat his patients, but he's also creating a lot of awareness on his YouTube channel. So welcome.
Thank you, Anu. Thank you very much for having me on the show. Thanks a lot.
So Dr. Jain, before we get on to the whole genomics piece, I wanted to understand, why did you become, a medical doctor, and why did you choose pediatric neurology of all?
Well, I wanted to become doctor right from my early days, from school days. What inspired me, at the time, I'm talking about, when I was in school, in early 80s. So at that time, it used to be more, glamorous profession, and there were not many, choices. There were two professions, doctors and engineers. So this profession always fascinated me. So I just chose to become a doctor. And your second question, why pediatric neurology? When I did my pediatrics, I did my MBBS and pediatrics post-graduation from Medical College, Rohtak. And in that space, I did see lots and lots of patients with pediatric neurology, and we would struggle apart from treating epilepsy and all the patients who had cerebral palsy. We just label them as a CP or MR, simply mental retardation, without any categorization, without any cause. So, since then, I was thinking of that, we should do something, we should go deep into that. Not every child who's not able to understand things properly cannot be MR. Okay, and now we are in a position that, we can tease it out further. What is the cause behind the learning disability? Or, we will talk about, genetics as well behind it, that has, enlightened us about so many diagnoses, and we are able to give prognosis to the patients and, obviously treatment as well, depending upon what it is. So that is the workload actually in India at the time that inspired me to. And that is the reason actually I chose to go outside, because at that time there was no formal training in pediatric neurology in India.
Correct. That was going to be my next question, that you went to the UK and practiced also. You did more, you studied there, but also practiced there as well, right?
That's right, yeah.
And do you think that there is a difference in terms of how we practice, pediatric neurology or any other field between the UK and in India, or any other place that you can see, or is it pretty much the same?
Yeah, we have lots of groups, and nowadays, connecting globally is not a problem. So we know what's going on in different parts of the world, including America. We have lots of friends in Australia and UK. Obviously, I was trained there. So we know, how the practices are. So in terms of expertise, I can't see any dearth of expertise in India now. Whether they are trained in India or they are trained abroad, we have fantastic doctors in pediatric neurology, very knowledgeable people, and all the resources available here. The only thing that I would say, when you ask what's the difference between your practice in the UK and in India, the pathway of the patient is not clear. In the UK, you never have to think about getting a patient. GPs would refer patients to you directly, and rather you would have a waiting list. In Oxford, when I was practicing, I had a waiting list for about 2 months actually.
Wow.
Yeah. Pediatrician could refer patients directly to you, so you do not have to seek patients from anybody. While in India, in government structure is fine, but government doesn't have enough jobs for everybody. So if you look at, not only pediatric neurologists, any doctors, most of them, they are employed by the either private sector, corporates, nursing homes, or they have their own clinics or whatever setup they have. So, pathway is not clear. Pediatric neurology patients being seen by everybody, adult neurologists, general pediatricians, even physicians could see. There is no strict regulations, about it. So that is the problem. You have to think about your bread and butter and everything, so that doesn't get off your mind. So that's a huge difference.
Correct. No, I think that makes a big difference, because I think if you had more maybe structured way of getting it, then everybody focuses on that specialty rather. And even general physicians can start off and then refer, right? But I guess it is up to us to evolve this, maybe the system that we currently have.
Things are getting better. I mean, I'm practicing in Gurgaon for the last 9 years now, and I have seen things evolving a lot. Now, pediatricians are, good, I would say, in referring the patients. They wouldn't want to, sit with the patient if they have, little, uncertainty about the diagnosis or the prognosis. They would keep low threshold to refer those patients.
So, but in many ways, I guess it is a good thing for the patients, right? Because they have a choice. They are able to see. But maybe it'll be better if it was streamlined a little bit more. So, in many ways,
that's good actually. No, you touched upon that point. Like I said, in the UK, I had a waiting list of at least two months. But in India, the beauty is patient can directly come from community. Sometimes, what happens? Patients search me on the internet. Sometimes they see the YouTube video. And they just, obviously they grab number of clinic or Fortis from whatever sources, and they get to seek an appointment, and we get to see those patients pretty quickly. So, that's the beauty of, this structure, I must say, yeah.
So today, I think a lot more doctors are using genomics, but I think as far as I know, you have started using it ahead of many other people. So how did you learn about genetic tests or genomic tests, and when did you start using them?
We are still learning, actually. 9 years ago, I still remember one patient was referred to me from Jaipur. That patient had, and he got MRI done, actually, and it was clearly, on MRI, you could say it was adrenoleukodystrophy. But obviously, you need to, before you give kind of such a bad diagnosis to the patient, you need to be 100% sure about it. So to that patient, I suggested, these are the possibilities. There were very few labs at the time, not many. Handful of labs. I think one was this German lab, Centogene. MapmyGenome had just started operations at the time. So I just, gave the sample from my clinic, actually. And then we cracked the diagnosis of, that was my first patient whom we got the diagnosis of adrenoleukodystrophy. And since then, the journey has been good. We've been able to make so many good diagnoses. Right from, I would say, different type of leukodystrophies we have diagnosed. And few of them, actually, we had offered, who were in very early stages. We had offered bone marrow transplant as well with good outcome. So that's a very good, part of this genomics that has helped us to reach up to that level. And we are evolving, we are learning day by day. And not only leukodystrophy, we have diagnosed a lot of metabolic problems with the help of genetics. And particularly recently, I have diagnosed like 2-3 cases of glutaric acidemias, which were kind of missed initially with the metabolic screening. And we have diagnosed creatine deficiency syndrome with the help of whole exome sequencing. And the best thing is you could do something about it. You could change the diet of the patient. You could start some other supplements. And these patients, they do pretty well if you diagnose them early and start treatment.
Yeah, I think that is the biggest challenge that I think for a lot of the medical professionals, this is not something that was part of their syllabus. And so they don't, I think what is important for them to understand is that there is a clear, actionable step that are there when you do a genetic test, right? And I think probably once that awareness spreads, I think we'll see a lot more people doing that, because at the end of the day, I think from a physician's perspective, I think the important thing is to either you diagnose better or treat better in many ways. Right? And I think it is great to get those examples from you in terms of how those have been helpful. But you've also been using pharmacogenomics in a fairly, you use that for understanding some of the treatment options, right? So how, and have you used pharmacogenomics?
I have tried, honestly, I have tried using that. I was, my theory was like, yes, in epilepsy, we have been using it and in other genetic disorder as well, as I have said. So pharmacogenomics, they have role. But I was thinking in terms of epilepsies, if you diagnose certain type of epilepsy, channelopathy, And then obviously we come to know this particular medicine, this is sodium channel blocker. It would not work in, SCN1A mutations. So it does help a lot actually, that earlier we are using certain medicines. They are the sacrosanct medicine for epilepsy. But now having had the diagnosis of genetics, this is the contraindicated medication. So yes, it does help.
So I think that's one of the things that we are trying to see if, how to make that whole pharmacogenomics journey a little bit easier and more straightforward so that it becomes easier for physicians to also understand, how we can look at pharmacogenomics and come up with a low cost alternative in many cases. But you're an expert. So in many cases, I think you can look at a patient and figure out a lot of the diagnostic aspects of it. But what if, you look at a far-flung area where it's hard for people to do? Is there some way? And I think I remember seeing a little bit of how you were using an app to sort of come up with some diagnosis by having a physician on the other end, of course. But maybe if you can explain, how do you diagnose all of these using technology in some way, that you have developed or your team has developed?
Yeah, that is because neuro rehabilitation is part of neurology. So we do see a lot of kids with learning difficulties, developmental delays, and autism, or autism-like, conditions where child is not speaking in time, child doesn't have good social, repertoire with the colleagues. So we have developed an app called Cogniable, where we are diagnosing these cases early. We have developed a very simple screening tool where if parents, or a physician or any stakeholder whosoever involved with the child, even schools, they can spend, 5 to 10 minutes and they could screen the child for autism. And we have done fairly good number of trials, and, it is 99%, accurate, in reference to CARS, which is a standard rating scale for autism. And we are also, developing a marketplace for all the therapists who are involved in it, in which what we are doing, we are enabling, parents and therapy centers who are sitting at remote, who do not have access, who do not, treat children with autism. They do not have ABA therapy. So we are empowering them. We are providing them course, we are training them, and we are hand-holding them to be able to provide those therapies with the help of app. And our app does have all the, relevant videos in it. Wherever a therapist gets stuck, he can take help of, from the videos that have been attached to a particular task, designed by the therapist itself, depending upon the assessment of the child. So it has been getting very good traction. We've been using in 15, 16 locations at the moment within India and outside, in US, Singapore, even Pakistan, one clinic we have just signed up. We are getting good traction. So at the moment we are just evolving, and obviously, we are getting good partners we met other day as well, just to take it further.
So one, I really appreciate your videos in Hindi also. I think I was not many videos that you can find that give you that sort of an information. So I think that's something that I have to learn also to make sure that some of the things that we talk, I think when we don't have the local language expertise, I think it becomes harder for people to get knowledge. So I did see a lot of your videos on epilepsy, also on several other topics. But if you can just paraphrase for us, epilepsy is of many kinds, right? I think you mentioned in one video about the Bukhar wali epilepsy and others. So can you explain maybe how many types of epilepsies are there, and if it is not genetic, then there are also some are genetic, some are not genetic. Maybe in short, if you can explain to a layman.
Yeah, see, epilepsy, you want me to speak in Hindi or?
Put it up, if whatever is comfortable with you.
All right, I think this interview is in English, so let's stick to English, Epilepsy is of different type. One is febrile seizure, which we do not call epilepsy, because more than 90% kids with febrile seizures, they grow out of it after the age of 5 years. But yes, some of the febrile seizures, they have connections to grow into a genetic form of epilepsy. Like sometimes they start with the febrile seizures, particularly Dravet syndrome you would have heard, sodium channel mutations, and they can have a spectrum of epilepsy. Sometimes JEPS plus, we call it, generalized epilepsy, febrile seizure plus. They also have linkage with genetics, although they start with febrile seizures, but it can cause problem. And once we are off febrile seizures list, then epilepsy is of different type. I mean, if you look at the international classification by International League, it could be your generalized epilepsy, where the child can have generalized stiffness of the body, eyes are rolling, sometimes frothing, loss of consciousness. It could be focal epilepsy, which means the child is shaking one part of the body, or one part of the body is not working properly, maybe one arm or one side of the limbs, eyes turning to one side, not up, mouth twitching to one side. Any of these movements could trigger or could be suggestive of focal epilepsy. Then, there are other, absence epilepsies. You would have seen children around after age of 5 years or so, they get freeze. They are talking to you and they will just get numb for, 5 seconds, 10 seconds. They won't do anything. They will just stay still. And sometimes slight, twitching of eyes, and sometimes, mouth automatism, we call it. And then they come back. But the bad thing about it, they don't remember anything, what happened in that 10 seconds. Oh. So for example, if you are, let's say, 8-year-old child sitting in a classroom, your teacher is, giving you a lecture, and you just miss those 10 seconds. So it becomes very difficult for you to get up. Because these absence epilepsies, it happens many times a day. So some children could have up to 100 episodes per day. So you could imagine the scholastic performance of those kids who have absence epilepsy. So it is extremely important to catch them early. And the treatment is beautiful. I mean, more than 90-95% kids with absence epilepsy could be treated successfully with medications.
But they have to come early to a physician then.
Yeah, otherwise they would lose, the scholastic, academic grades, whatever, they have.
So almost you're saying that in these cases, 90% of the cases, if they come early enough, I think they can be.
Yeah, absence epilepsy is very rewarding for doctors and for parents both, actually, if they get it done.
Now, one of the things, for instance, is that you've also mentioned that 70% of all, most of these children, if they come to you early, not just one class of epilepsy, but everything can be treated early. Do you think that if there was a possibility of doing a genetics or a genomic screen upfront, so you can understand that maybe parents will recognize some of this ahead of time rather than wait till it becomes, because a lot of times I think parents are often in denial, when there is, so instead of getting treatment, they are hoping it'll go away on its own. So do you think that by looking at it from a genomic screen, is there any possibility that they can understand a little bit better and hence seek advice earlier?
Yes, nowadays I tell you what we are doing. Because these genomics, they are pretty expensive, and we do get patients from different backgrounds. Many people who cannot even afford a laboratory stamp sort. They are so poor. We think about writing laboratory stamp. We just hang on to carbamazepine and these kind of drugs, so that, because it's a long treatment, at least 2 years, 3 years we're talking about. So it depends. So generally, since more than 70% kids, they respond well to the first line of therapy, I generally do not get involved into too many genetics to begin with. I usually get an MRI scan just to see if there is any structural problem. Then I get an EEG that might, tell us about the type of epilepsy, what we're dealing with. Then I start the medicine straight away. If I struggle to, treat the child with monotherapy, then we open the second line of investigations. And we do mention that, yes, there are possibilities that it could be genetics. And the main hurdle we found in this genomic era, even now, although it is much cheaper as it was, 9 years ago, when I ordered, I still remember clinical exome sequencing, I ordered for 35,000 rupees at the time. So the cost has considerably come down, but still it is not affordable for many. So as a first line, we do not suggest that. However, some parents, they are keen, they want to know about it. Then obviously, if parents ask something, you can just, suggest them, what is the best way to go about it, and they can get it done. But generally, I do not advise in first go. But yes, answer to your question is, it would be good. There is no harm in getting it done. If you can afford it, it is better to get it done early and just to know where we are. Because sometimes what happens, parents say, Doctor Sahab, हमारी family में तो कुछ नहीं है. I mean, how could it be genetic? So genetic का ये मतलब नहीं होता है कि आपकी family में अगर कोई epilepsy नहीं है, तो इस बच्चे को genetic नहीं है. It just means that there is some problem in the genetic makeup. Where it has come, sometimes we can trace it back to the parents and the grandparents. Other times it may not be possible. But if we can know the clear-cut cause, clear-cut gene behind it, then we can help you in the treatment and we can help you in the prognosis as well. Because parents have so many questions. How it's going to behave, how it's going to the learning and intellectual, property of the child. So all these things could be answered pretty easily if we know the exact diagnosis.
And one more big question, and I think it is coming up more and more, is about autism, right? I think there are autism is at least I hear, and maybe because I'm in the genomics field, we see a lot of cases that come to us trying to understand autism. But from your perspective, when you as a pediatric neurologist see, I'm sure you get quite a significant number. So how common is autism, and are parents coming to you who have done some sort of understanding prior to having the baby, or usually these are parents who never did any testing upfront to be able to get there? And are they, how common is it? I'm not able to frame this question well, but
sure. So I must say it is common. It is common. And now we are getting good data from India as well. Last year after COVID, I have seen one paper from AIMS, Dr. Shefali Gulati has done quite a lot of work in autism. So we are getting, very good data. And as I said, knowledge is not a problem. But if I tell you about, US data, approximately you could imagine 2 children out of 100. So 2% children of all, whatever, new children we are getting. So they are kind of, suffering from autism. So it's a huge number if you look at the disease load actually in the community. And particularly what we have seen this COVID period in the last 2 years, we have got surge of, I'm not saying that, this lockdown has. I'm really sorry. I think you have to edit. I think, I just had a phone call and then it got disturbed.
No problem. That's advantage of not being live. Yeah.
So we are getting a lot of children who are on the autistic spectrum, and again we are getting patients from very diversified background. Some parents are very much up to date. They have gone through Google, internet, and even some of them have done the MChat as well. And they know fairly that there is some problem. They may not accept it in first go. But they are kind of, amenable to early intervention, and they get the benefit out of that as well. On the other hand, there are a spectrum who would say, no, my child cannot have autism. There are many children who start speaking late, so it doesn't mean that it is autism. So, they have to be counseled. Sometimes, they understand what we are saying. Other times they go to different doctors, and when they hear the same word from 4 or 5 different, professionals, then they come to the term that yes, there is a problem. So my message here is, see, what I say to parents, even if you label the child, sometimes, we are in the gray zone. You do the MChat, whatever, car scoring, ADOS, whatever you want to do. Sometimes they just come on the edge. Okay. So message to parents is, even if it is spectrum, autistic spectrum, or you are falling slightly outside. If the child is having problem in speaking, the child has some stereotypic repetitive movements, suggestive of autism, but may not be reaching up to the scale, there is no harm in starting therapies. It doesn't harm you. Okay. Even for a neurotypical child, let's say I claim that, I'm a neurotypical, but I don't know, how other people think about me. Even if I take some coaching about speaking, public speaking or so, I'll get some improvement. There's no harm. So that's how I tell the parents. Some people understand it and then they just get on it and then they see the benefits of
it. So hopefully, I think people realize that it is not as it will help even if you're just a late speaker or anything, but going through these therapies early on will actually help. If
Yeah.
if they have an autistic child, or even if they don't. So I think it's important to take an early intervention in many cases. Right?
Absolutely.
One of the things, for instance, is that maybe people can look at a lot of the neurological problems, look at it from screening upfront, and even before they have a child, right? I mean, now we are seeing quite a lot of the OBGYNs and others who are actually prescribing, one is the NIPT test, and also many of them are actually doing carrier screening and all of that. So you can at least understand a little bit upfront before you actually have the baby. But do you think that at least, let's say somebody's already had a baby, an early intervention, like you mentioned, can help? But if it was, it takes, I don't know how quickly some of these actually show up, but if it shows in the genetic screen, that might actually help, or do you think that it is of not of much use, especially if it is there in the family?
Yeah, I mean, again, autism also does have a lot of links with the genomics. There are certain syndromes which are straight away, can tell us, like Rett syndrome, tuberous sclerosis, that they are going towards, epilepsy or autistic spectrum. There are lots of other deletion duplication, like, Angelman syndrome, 5p deletion, 14p deletion. So lots of things. I mean, whether to screen them to begin with, I'm not sure. I mean, whether we get the number to treat, how many kids we have to screen to treat one child. So we have to look at the data. But yes, if there is any positive family history, then we do advise them to screen if there is a newborn in the family, so that we know, if the child is having the same issue, then we can better prepare ourselves and the resources.
Okay. So with this, I mean, if you have some words of medical advice that you, or any other advice that you want to give parents, after that, I'll have a quick rapid fire round with you.
My message to parents is always early intervention. It is better to be prepared than having an, unexpected accident, I would say, or some incident that we are not prepared to handle, whether you are flying somewhere or, airplane, crashes, and it is difficult to handle. If you have planned certain things, then life is easier. So screening definitely is a big way. You have given example of like newborn screening. So it was there in the Western world for quite a while, many decades actually. They do the Guthrie card and all, and they do catch a lot of metabolic problems in it, thalassemias, hypothyroidism, and they are potentially treatable things. Okay, so it is good practice, but again we have to see the data, and but definitely if we have somebody in the family, there is a strong family history, then it is better to screen the child earlier than later.
Yeah, actually now we've started adding some of these carrier screening, like thalassemia and others as well, on G6PD and a few other things on genopathy itself. So at least the parents themselves can know that if there is a possibility, and of course I think our aim at least has been to reduce the cost.
Because what I have seen sometimes, parents, even before the first child, parents get the whole exome sequencing done. Just they have read something, or it is difficult to analyze the data. If you get VOUS, if there is no index case and you do the screening, you've got whole exome sequencing of both the parents. It is difficult to analyze, where we are. And then it creates lots and lots of anxiety because you are going to get lots of VOUS.
I think one of the, sometimes our analysis teams, when we ask them what is the problem, because we said that, in the end, we don't want to bombard you with like too much information, right? So when you do a exome sequencing or a whole genome sequencing, sometimes they ask us, why are you asking me? You should find the solution, right? And we tell them that maybe we'll find something that, right now it might not be that relevant. It's a good thing that we can look at later, but we have to understand what your problem is to be able to give you that analysis or a deep depth analysis of that. But, and then on the other hand, we have things like genopathy, where we are doing a more standardized version of saying, are you a carrier of something or not? But I think that's the difference. I think people have to understand that there is some things that you can look at it from a more standard way of screening. And then there are others where if you're doing an analysis on an exome or anything else, that you really have to find out and focus, like you said, instead of saying I can give you all the US or the, things that.
So that's what we have been doing at the moment. I mean, we are doing very targeted, genome testing, I would say, because they don't come to us in first place. Parents would not come actually. They would probably go to either gynecologist, if they are worried, if the lady is pregnant and they want to know, things about it without any, indication as such. So, but we do order the targeted thing most of the
time. And one last question. Do you think genetic counseling is important?
It is extremely important. Extremely important, actually. I like your word, this genome patri, because, we are all from that sort of, Hindu system where, when you are going to get married to somebody, so people used to do this, matching of genome patri and all that. Okay. So, I mean, genetic counseling is equally important. I mean, when you are, marrying someone, so it is good to know the history, of both sides, whether there are some, recessive disorders that could pop up if there is. So it is important even before marriage. I mean, it is good if there is some history popping up, then you could do the exome sequencing or genome sequencing of both the, eligible candidates and see, if there are some potential. So yes, there is way forward.
So one of the other things, and I know I told you it was the last question on
yeah, that's all right.
But one of the things, what we have been looking at is sort of integrating a lot of data types, right? I mean, whether it is when we work with somebody like Total Brain, we are saying we integrate an app with genetics. When we are looking at genome patri, we are now integrating it with your actual health, like a preventive health data. Do you think that, if it becomes simple enough to use in terms of saying, you take genetic data, but you also take other data, like whether it comes from, your cognable or whether it comes from a blood test or others, if we can find a way to sort of think about it from an integrative point of view.
It's a great thought, actually. It's a great thought. I mean, since we are, planning to go to the preschools and to the pediatricians, to screen for development. So at the same time, the main, maybe my style of thinking or teaching, when we screen for something, we should have, something to offer, actually, if it comes positive. So that's the, thing. So we are offering, let's say, screening for autism at preschool or at the pediatrician level. So if we diagnose, yes, clinically the child is looking like, on the spectrum. So let's start the intervention. But let's say the same, we have done the this genetic testing or genetic screening at the same time, and we came to know that there is some 9p deletion. The only thing is, what do we do about it now? I don't know whether I'm thinking right or wrong, but yes, it is a way forward. It can be bundled together. The other thing is, cost has to come down. It has to be really, really low so that it can become part of the screening. At the moment, it's expensive, I must say. But yes, it would be a good value addition, actually. Good value addition if it is bundled with proper counseling. Because if something comes up that we cannot reach, it would cause anxiety in the parents. So that should be counseled pretty, meticulously. Then I can see, there is a future behind it. Yes, definitely. And we can do it, I guess.
So our plan is really to bring down the cost to, already like a genome patri or a Medica map, which you saved my number as.
Yes.
To be able to bring it down to a level that anybody can afford and anybody can create a profile, because that was more to be able to create a profile for all kinds of medications. So whenever you need it, you have access to that.
I was discussing somebody in US. They are developing nanotechnology, and he was of the view that now exome sequencing takes about a month to come back, and it's pretty expensive.
3 weeks.
He said we would. Sorry.
We are taking 2 weeks now. 2 to 3.
You are taking 2 weeks now. So he was saying with the nanotechnology, then, it could be just like, you do the screening, you do the, tactile luminometer, you just touch the screen and you get the data. So, that's the kind of thing, actually, maybe in a few years, if we get with the pretty accuracy, actually, that's more important. Otherwise, again, it's unnecessary anxiety. But yes, world is moving towards that.
Great. So thank you. And now let me go to the more fun part. And I realize that a lot of people listen to this very, seriously. So let me start the rapid fire. So one, of course, you're a outstanding pediatric neurologist, but was there any subject that you didn't do well at in school?
I never thought of history, actually. It was sounding boring to me, and I was never good at it.
And where were you the best? Biology or?
I mean, my maths was pretty good, actually. I studied maths up to 10th standard. I was from Haryana board. So I still remember I scored 94 marks, actually. At that time, getting 94 were not.
Oh, it was great.
Now people are getting 99.9 and all that. So
I think I remember my brother is 7 years older, and he kept telling me that when I got my marks, we were already inflated. And then from me to when it went to my kids, I think we keep saying that, things have changed in terms of how marks are given today, right? Compared to today.
Very liberal, yeah.
So any hobby that you have?
I mean, traveling and exploring new things. We always, up for it, yeah.
And any favorite book or movie?
I like the movie, it's Russell Crowe's Beautiful Minds.
Oh, I love it, yes.
Yeah, it's a fantastic movie, yeah. Another thing, second attached to it is, there's a movie on Stephen Hawking.
So I think you like similar movies, and we have similar taste in movies then.
Yeah. The reason, I like both of them, in Stephen Hawking movie, he's physically actually, he's pretty much, is a condition where he would deteriorate and he wouldn't do much about it, but his brain was intact and he did the wonders. And second, he had schizophrenia in Beautiful Mind, where his brain was not in his control. And again, with the physical and with the intent, he did the wonder. He got the Nobel Prize. So, you don't have excuses basically for your failure.
True. I think I remember I wrote a poem on the brain. I don't have the access of it right now, but at some point I will maybe write.
All right, great. That'll be great. Yeah.
Any favorite destination or city, town other than Gurgaon?
Oh, you just, I was going to say Gurgaon, it's one of the best places actually for everything, for academics, for hangout. It's a good place. But my second city would be, London. I have spent a lot of time in London, and it's a vibrant city, You ask for it and it's there in London.
Thank you so much. I think this was wonderful. And if you want to say anything, any last words on the show, that would be great. Otherwise, we'll stop the show here. And thank you.
Thank you, Anu. That's a good show, and I'm pleased that you are creating this awareness. And genomic is the future. I'm pretty confident. I'm sure you would be aware about, there is a Cathy Wood who runs a fund. Whether you record it or not, I don't know. She does have a fund on genomics, ARK, genomic fund.
Yes.
So I'm very bullish on it. So there is a future. Genomics would do well.
That's what I believe in. That's why I've been in it for 22 years. So I certainly hope.
You've been 22 years. Wow.
22 years, yeah. So this is MapmyGenome is my second company. I had a company called Osibum before, but there we mostly worked with pharmaceutical companies and biotech companies. And then we actually created some of the largest databases that pharma companies use for drug development and others. But I think I wanted something where we could have a direct impact, and that's why.
Excellent. Yeah. Great. Thank you very much. Thanks for having me.
This was fantastic. Thank you again.
Thanks.
I will stop the recording.